identical results. So one non-union, I think, out of 100 patients in the operative group, and about 25, I believe, in the non-operative group. So very similar results. If you look at symptomatic non-union, not all these studies did, because it wasn't really much of an envy back then. But it's the same thing. There's a much decreased incidence of symptomatic non-union and non-union together. So it's reproducible. Other people get the same result. And you can argue about how you interpret the results. And one interesting thing is that if you look here at this Vertanen study, they had 5 non-unions out of 32 patients. This is a Finnish study, and what they said in their paper was that none of the Finnish patients who got a non-union really cared that much, and they didn't reconstruct the surgery, so it doesn't really matter. We don't recommend you fix them. So it's the identical results to ours, but they found that non-union patients in general weren't that symptomatic, so they didn't think that they should routinely fix people. So that would be just a difference of interpretation. I would think most active North American patients would not be happy with non-union would eventually get fixed, but again, that's something for later, I guess. I'm going to digress for 1 second about the importance of your research staff. This is a study again by Lynn Crosby's group. So after he published that first paper where he said a lot of people are unhappy, he embarked on a randomized trial, which is identical to ours. In fact, this is where I got a lot of the ideas for our study from. So he was an operative versus non-operative treatment in a randomized fashion for clavicle fractures. And this was published in an abstract form, I should say published, presented in the abstract form of the American Academy in 2001. So years before ours came out, he presented this study. It's almost identical in terms of treatment or the strategy design, the protocols, etc. I'm not going to talk too much about it. We had 49 non-operative patients, and we found roughly the same thing. There were 12 non-unions in the force, about 16 people out of 49 were unhappy, very similar to our study. This paper was never published, and it wasn't published because they lost a tremendous number of patients to follow up, and a lot of the data was missing. Because they didn't really have good research coordinators and nurses helping them. So I put this up here to demonstrate how important it is to work in this kind of environment as part of a group where you can do a proper job. As a busy clinician in a fracture clinic, you cannot do this kind of study accurately or well. You have to have help. And they lost so many patients to follow up, and they did incomplete data on so many other patients because they didn't have that research team with them. That the paper was never published, and it still hasn't been published. So I want to illustrate the importance of having a team like that, practically speaking, to make sure that you do a good job at this kind of thing, or else it'll never get published, and theirs didn't. And it demonstrates why you need to have those people working with you for this kind of situation. Well, what's happened to operates and clavicle fractures? So what has happened is it's gone up and up and up. So it used to be around 3 or 4%. This is a company. This is not scientific data. This is commercial data. It's from a company that it's called Pearl Diver. And what they've done, I don't know if you've heard of it or not, so the commercial company states that you can go to them with pretty well any question you have, like what percent of people with clavicle fracture get the clavicle fracture fixed, and they'll find that data for you. They're very skilled. They're all like research nurses, etc. And they'll give you that data for what you're looking for. And so you can see that the rate of operative fixation is going up. And I would suggest this since 2009 has gone up even higher and higher. We'll talk about the pendulum effect in a second. So it's clear that these papers have influenced practice, and these papers have also made it more aesthetically pleasing or medically pleasing, I guess you'd say, to treat a clavicle fracture operatively, and that's what is happening in these ways at the present time. I'll also say you have to be a bit lucky at times. So as we publish our paper, more and more people are talking about fixing clavicle fractures. Lance Armstrong broke his clavicle on a bike accident. And no, they didn't call me to come and fix it. I was waiting on the phone for a couple of days. But I never got the call. So a sports doctor later admitted to me that he hadn't done one before. Took him to the OR for a 4-hour operation and fixed it. This is off the internet, so I'm not releasing private medical information here, okay? This is off the internet. You can see this is Lance Armstrong's clavicle. I gotta tell you, I have no idea how we got those 2 screws in. I thought I called me kind of saying, seriously, how did you get those 2 screws in? So it's like a 12-screw plate construct. And it went great. He healed. As soon as that happened, all of their websites that bikers go to, etc., they all have this sort of rash of interest saying, if you have your clavicle fracture, you should go and get it fixed right away. There's all kinds of unsupported plans how to done. Well, so that was also, this was a bit lucky or gratuitous, and this also, I think, drove the incidence of clavicle fracture fixation way way up at the time. So it never hurts to be lucky to do this stuff as well. Mark Tile has a great slide. I don't have where it shows you what the pendulum effect of orthopedics. So what our problem is now, I think it's a problem, is that for so long the pendulum was way over the non-operative side, irrationally so. So no one fixed scalpel fractures. We all, even in the most obvious situations, didn't do it, etc. And now we've said it's okay to do it, so the pendulum is swung. And what we were trying to do with our paper, we put a lot of emphasis into that, which I don't know if this made any difference, was just to tease this back gently towards where it should be right here. You know, maybe 10% of clavicle fractures should be fixed, maybe 1 in 10 should actually be fixed right here. What has happened, unfortunately, especially in some countries, you know, and I won't mention any names, but they're south of here, okay? And it's not Mexico. It's that where people are desperately looking for any reason to fix a fracture, it's swung way too far over. So I get emails now saying, you know, Dr. So-and-so, I fixed my 80-year-old diabetic mother-in-law's clavicle fracture and it's pussed out. What do I do now? So we don't want that to happen. This is a select finesse operation for young, healthy people to displace fractures and benefit from having it fixed. So we don't want to see this ridiculous swing way over to, you know, every clavicle fracture comes to the door with a crack in the bone and has to have a plate applied to it. And again, to reiterate, a lot of people who have a completely displaced clavicle fracture will get put in a sling, will heal fairly promptly, and be fine. So the number needed to treat, if you look at all comers to the door, if all the randomized trials have been done, we probably have to operate on maybe around four clavicle fractures to prevent one symptomatic malunion or one non-union. So if we had a better way of identifying who's who when they come to the door, right off the bat, if we could finesse our indications to people who really and truly be unhappy, then that would make a huge difference. If we eliminate those people who are going to be okay, focus our operative implant reserves on people who really need it. And that's what we're trying to do now in this setting. What are we looking for in the future? Well, again, I'll mention Bill's papers in JSCS last year looking at scapular winging. Remember that picture of my patient group? The clavicle itself is just a strut, very few muscles of any importance along the clavicle. What the clavicle's main job and operational function is to do is to hold your scapula in place. Your scapula is where the money is in terms of where all the muscles come off, your rotator cuff is there, the main attachment for your origin, for your deltoid, etc. That's what's really important. If you have a simple clavicle fracture, it just shortens a little bit. And we use shortening, again, as a one-dimensional thing that's easy to see on an x-ray. It's kind of a surrogate for all that's going on. It may not be accurate. If your clavicle shortens a bit and your scapula stays roughly where it's supposed to stay, then you're probably okay. If your clavicle shortens and rotates so your whole scapula kicks forward, so you have a winging like this, and you can see the static winging. This guy's a bad clavicle now. I mean, this is a subtle case, and it doesn't show that well in light, but there's a difference here. You can see that's the malunited side. There's a difference in the contour here, which is much more obvious here. This is the malunited clavicle side. You can see the way the scapula kicks out there. It's a very characteristic thing to it. And there's many different kinds of scapular winging, as I found out subsequently. So the inferior pole kicks out, the whole shoulder kind of rolls forward. Again, like that picture in my patient group. Maybe those are the people who are going to be most unhappy. And there's some evidence that's the case. It's just very hard to prove it because this is a very three-dimensional thing that's hard to pin down, as we found in our paper. We thought it was something new here. This is great information. And so I gave this talk, and a physiotherapist in Detroit came up to me after and said, you should look up some of these papers. And there are 5 or 10 papers in the physiotherapy literature talking about scapular winging after clavicle fractures and how bad it is functioning. And it's quite true. If you put your arm out like this in front of you, like you would have with a typical displacement of forward or rolling forward your shoulder and trying to do things to see how weak you are with your shoulder protracted. But anyways, it's not news. The physiotherapists have a lot more information on this than we do. But I think this is one of the group that is probably a bad actor initially. If you look at it objectively, this is a 3D kind of CT reconstruction. This is a malunion on the involved side. This is a line through the midline here. The line goes through the back of the AC joint here, and you can see how far forward the AC joint is here. So again, it's like trying to do things with your shoulder forward like this. You don't have a lot of power when you're like that. So that's something we're looking at. And that, if I see that now on the patient, so if they're sitting there in the clinic, in the fracture clinic, I look from behind, look from the top, and see that shoulders roll forward, their scapula's kicking out, that's someone much more likely to say you should have an operation. This is another specific bad act. So if you have, it's interesting, that two of these patients like this, last year, so both orthopedic surgeons, if you have a ipsilateral clavicle fracture and multiple rib fractures, you see this guy's all started with pneumothorax here. So ipsilateral clavicle and multiple rib fractures, your whole forequarter is destabilized, like a crushed in chest. This is a bad natural history. This person should have an operation. I would argue at some point down the road we might actually be fixing the ribs as well, but right now we'll stick with the clavicle. If you see this combination of injuries, you should have that clavicle fixed. And I've seen two separate orthopedic surgeons, one treated non-operative who was bitterly unhappy with his results after this constellation of injuries. But when we fixed early, he was good. It's sort of a randomized trial of two, but obviously not very scientific. But I'm convinced that this is a bad actor. This is something we should at least have the clavicle fracture fixed. You may need to hear more about that in the future. As you know, all the pictures we've seen so far, fixed clavicles with plates, well, maybe the nails are good. The old nails we had have not been consistent. So we have the Rocco pin, the Haiti pin, and all these other devices. They had no rotational control. They didn't have much axial stability. They were not very good. It may be, though, that this is the one which is conducive to pinning. And there are some newer devices out there. We've used them. I don't know if they're perfect or what their complication rate is yet, because they've only done about half a dozen. But I tell you, it has some definite advantages compared to plating if it pans out. The problem with capacitance, things happen to pan out. So you may see some more about fixation, IM fixation devices. This is a sort of walkable one here. Has an expansion bolt here, like the old side-out nail that the humorists used to have. Hopefully this one works better than the side-out nail, which wasn't a great device. Gives you some axial control, etc. So maybe a role in selected patients for a IM pin. And those are some of the things we're working on now. Trying to find the patients more carefully, looking at specific subgroups that have bad prognosis. Maybe there's some better techniques. So all these things are an evolution. So we've established, yes, probably some people should be fixed, but all these other things are still up there. And you have to constantly evaluate who you are and see where you're going with these things. So where does that leave us? All this information is very important, because now when a patient sits in the fracture clinic across from me, I have good, solid information to tell them upon which to base the decision. And at the end of it, they say, what would you do? And I say, I have it fixed. But before, I would say, put it in a sling, you'll be fine, go away, blah, blah, blah. Now we can sit there and say, look, if you want to leave this fracture alone, which is fine, it's your choice, the chance of it not healing in a year is about 15%. The chance of it healing, but you being unhappy with it, is around the same 15-20%. That's what we call a symptomatic value. Now, people who do math quickly, you guys will say, well, so there's about a 60 or 70% chance if I leave it alone, I'll be okay. And I say, yes, that's absolutely true. And how to use that and make a decision. In general, I tell them, if you have it fixed, you're probably a few points better than if you don't have it fixed. I also tell them the worse the deformity, especially if I see that scapular wounding, then you're more likely, and I didn't present it for the sake of everything, but the more shortening you have, the more likely you are to have scapular malposition. The more deformity you have, the more likely you are to be unhappy. If you're sitting in the clinic looking at some of the clavicle fracture, and you can see an obvious asymmetry between two shoulders, that usually is about 1.5 centimeters or 2 centimeters of shortening. Less than that, you're not going to notice with the naked eye in the person with normal body habits. Once you start to see a clinical asymmetry, it's around 1.5 centimeters, 2 centimeters of shortening. So I tell them that as well. If they're really short, they're put in their scapula scheme, I said, you're probably someone who's going to be less likely to be happy soon. And that all these points are things you can tell a patient now, not to force them to have an operation or force them to have sling, but to use it to make a decision. So it's not stuff that we have now in our armamentarium to force anyone to do anything. It's just now getting information you can use to make a reasonable and rational decision for the patient dealing with someone who self-employed, like a chiropractor or dentist, and wants to get back to work quickly. I can say, yeah, for sure you will get back to work quicker if you have this operation. You'll probably be about 10 points better in the long run. You'll take the risk of having non-union value down such and such %. And so in general, it's actually good for us to want to have it fixed. And we have good scientific backing how to fix it before.